Celexa side effects. My name is Dave. I'm a pharmacist, and you might be wondering, why do I have a woman standing on a pill? Exactly. Celexa, generic name is citalopram, is a selective serotonin reuptake inhibitor, or an SSRI. The goal with these drugs is to amplify the effect of serotonin, which is also known as the feel-good hormone. The basis for this is the serotonin hypothesis, which was conceived in the 1960s. Basically, the idea is depression is associated with some kind of deficiency in serotonin in the brain. And if we just correct that deficiency, then we can eliminate or dramatically reduce the depression. Now, I don't necessarily completely agree or disagree with that at this point in the presentation. Let's just roll with it. So where does serotonin come from? So there are 21 amino acids that are common to all forms of life. Among those, there are 9 quote-unquote essential amino acids that the human body needs but cannot produce on its own. So we have to get these 9 amino acids from dietary sources like plant protein or animal protein. And one of those is tryptophan. So we consume protein that has tryptophan because amino acids are the building blocks of proteins. So you eat the protein, eventually you get this tryptophan, and then the body has enzymes that can convert that to serotonin. Serotonin is a hormone, like I said, but it's also used as a neurotransmitter. In other words, neurons or nerve cells can use serotonin to transmit nerve signals. And if you look in the human body, where's this serotonin concentrated? You're going to find it in a high concentration in the central nervous system or the brain. And you're also going to see it in the gastrointestinal tract and in platelets, which are in the blood. So those are the sites where you're not only going to see the potential therapeutic benefit in the brain, but you're going to see potential side effects in the brain, in the gut, and the blood, which we're going to talk about. So there's the brain. If you zoom in on the brain, you'll see it's a vast network of neurons or nerve cells. And if you zoom in on a connection between those nerve cells, you're going to see this. This is called a synapse, this connection. And here, this nerve cell is sending a signal. These little squares represent serotonin. So it's using serotonin to send a signal to the next cell. When the serotonin binds to the receptor binding site on the next cell, it triggers basically a signal to be sent. So this is a very efficient process. So the serotonin that's not being used, that's not binding down here, ends up getting recycled by this. This arrow here represents a protein that takes the serotonin back and recycles it. So if you block that protein with a selective serotonin reuptake inhibitor, then the serotonin has more time to hang out here, more time to interact with and bind to these receptors, effectively enhancing or amplifying the effect of serotonin. And that's the whole idea. Like I said, the GI tract there, another site where serotonin is found in rich supply. And serotonin also, I pointed to this area here, involved in blood clot formation. So there's going to be side effects in the brain, there's going to be side effects in the gut, there's going to be side effects in the blood. And the main side effect in the blood is bleeding. You're interfering a little bit, just a tiny little bit, with blood clot formation. And that risk really is relatively negligible unless you're combining the SSRI with an NSAID. Now, what's an NSAID? That's a non-steroidal anti-inflammatory drug. Examples are ibuprofen, naproxen, aspirin, diclofenac, meloxicam. I could go on. But if you take an NSAID by itself, on average, that will increase the risk of an upper GI bleed. In other words, a bleed in the stomach by 7.8 times. So the baseline risk is very low. But if you take an NSAID, you're multiplying that very low risk by 7.8 times. And then if you stack on an SSRI, so you're taking the NSAID plus the SSRI, you're increasing that risk to an overall 8.3 times higher risk of upper GI bleeding. So that's not a dramatic increase when you compare it to the NSAID alone, but it's something we try to be aware of, especially if someone's taking other drugs that can interfere with blood clotting. So the neuropsychiatric side effects, I listed them here from top to bottom, ranked in terms of how frequently they occur. The most common side effect with Celexa is a dry mouth, and then there are sleeping problems. Some people, when they take this, they sleep a lot. Other people have insomnia. They have trouble sleeping. And then we have basically kind of these like anxiety type of symptoms here, like sweating, tremor, anxiety, anorexia, and agitation. So if you look at how frequently these side effects occur and you compare the Celexa group to the placebo group, you'll see that they're kind of close. Celexa is always higher than placebo, right? But placebo is always not far behind. So what's going on there? And I have a theory, and my theory there is that the people who are taking these medications, right? If you're in the trial, you're being given a drug or you're being given a placebo, but you're told it could be the drug and it may not be the drug. You don't know. All right. So if you're the patient and you're taking this medication and you have depression, you're kind of hopeless as a consequence of the depression. You have negative expectations. And so I think there's something going on here called the nocebo effect. So we're all familiar with the placebo effect. That's kind of a positive thing, right? The placebo effect, the term applied by medical science to the therapeutic and healing effects of an inert substance, such as a sugar pill, in conjunction with the suggestion from an authority figure, like a doctor, that the pill will aid in healing. And that produces a powerful positive outcome. Just this association, like, oh, this could help me a lot. So that's a good thing, the placebo effect. But there's also a flip side to that. It's called the nocebo effect. You could be very skeptical, very suspicious. You could have a very negative attitude toward this pill that this doctor is giving you. And you could say, well, I think this is going to hurt me. And you can believe that. And having that belief can produce negative symptoms. And I think that's what we're seeing when we see all these placebo-related side effects. So, like I said, depression. One of the words that pops up all the time with depression is hopelessness. There's an association there. Hopelessness is a downstream effect of depression, or vice versa. And then what is hopelessness? Basically, negative expectations. And then that pretty much encompasses the nocebo effect. The nocebo effect is born out of negative expectations. So just kind of trying to explain what's going on, because look at this. Once again, nausea and vomiting. Placebo, a lot of people who took the placebo experienced nausea, and quite a few people vomited. I mean, that's powerful. Like, these people must have been thinking, this could hurt me, and it made them anxious and they threw up. But there is a slightly higher rate, like I said, of side effects in the Celexa group. So something is going on with the Celexa, but I think mostly this is just a consequence of negative expectation. So other side effects, some sexual side effects. You can't make this stuff up, people. Ejaculation disorder, impotence, dysmenorrhea, decreased libido. Also some respiratory side effects like infection, rhinitis, sinusitis. So interesting. Also, okay, this is kind of an interesting thing here, kind of a big deal, especially if you have a kid who's taking an SSRI or any antidepressant. So they've done studies and they found antidepressant use is associated with an increased risk of suicidal thoughts and behaviors in young people aged 24 and under. So if I hear that, to me, that's not enough information. I want to know, okay, give me some numbers. Like, are we talking like 1 in 100, 1 in a million? Like, can you help me out here? So I found a paper here that kind of provides numbers. Now, it doesn't differentiate suicidal thoughts from behaviors. It just groups them all together. So the first line there, pediatric, this would be people who are under age 18. In those who are taking the antidepressant, 2.53% of them experienced suicidal thoughts and or behaviors. Now, when I say suicidal behaviors, what do I mean? Basically, we're talking about like they're actually planning it, potentially attempting. Okay, so 2.53%, that's a little bit more than 1 in 40. So that's a lot. That's a lot. Compared to placebo, 1.25%, that's like 1 in 80. So something going on there. And then, like I said, this effect is only seen really in people who are 24 and under. When you get to this higher age range, like especially look at 65 and up, the antidepressant is actually providing some sort of a protective effect in the elderly population. They have a fraction of the chance of experiencing these suicidal thoughts and behaviors compared to someone who's taking a placebo. So that's very interesting. Now, keep in mind, I just want to say depression and other psychiatric disorders are themselves associated with an increased risk of suicide. So not using, like avoiding altogether antidepressants because there is this potential increase in suicidality, not necessarily a justifiable decision. I would say, monitor super close, be super attentive. And, people who are young may be in, dire need of an antidepressant. So just keep that in mind. Now, I want to revisit the serotonin hypothesis. Remember that whole theory from the 1960s that said low serotonin is the cause of depression, and if we just correct that, then the person won't be depressed anymore. So if you look at like SSRIs, they should be really effective, right? They should be super effective if that theory holds true, right? If it's just about low serotonin, then SSRIs should be awesome. So this meta-analysis looked at randomized controlled trials, and what they found was there's about a 20 to 30% advantage of an antidepressant compared to a placebo. So a slight advantage over placebo. Now, if you take that's looking at everybody with depression. If you take the whole group of people with depression and you divide them into groups like mild depression, moderate depression, severe depression, and very severe depression, like let's look at it that way. This study did exactly that. The only group that had a clear benefit from the antidepressant drug was the group with very severe depression. All the other groups, the mild, the moderate, and the severe, they had a non-existent to negligible, the antidepressants had a non-existent to negligible effect. So, man, I don't know. Like serotonin, the whole theory that it's just serotonin doesn't really seem to be holding up. Here's an updated perspective. This is a quote from a paper. Nowadays, it is generally accepted that recurring mood disorders are brain diseases resulting from the combination, to various degrees, of genetic and other biological as well as environmental factors evolving through the lifespan. In other words, these things are complex, okay? It's not just about one neurotransmitter. It's this whole picture of genetics and biology and environment that's influencing what's going on. So I want to talk about exercise today, and I'm not trying to just like minimize this and say, hey, depression can be treated with exercise and you don't need drugs. I'm not saying that at all. I just want to point out, here's a paper. This is a quote from the paper. The effects of aerobic exercise on major depressive disorder remission seem to be similar to sertraline after 4 months of treatment. Okay, let me restate that in a way that you can understand. Zoloft, 4 months of Zoloft, similar in effect to 4 months of aerobic exercise. Seriously, I mean, that is a strong statement. So exercise is really effective. And they go on to say that basically exercise may augment the benefits of antidepressant use. They followed these people for a full year, and they continued to see a benefit from the exercise. So exercise is a big deal. If you're interested in learning more about how exercise combats depression, I found some resources, and I'm going to link to them in the description below. One is a book. It's called Spark. And then the other one is a paper. It's a free paper. You can click on the link and read the paper for free. And I highly recommend both of them. It's very important that you exercise, and you may not be able to do much exercise. You have to start off small. Do whatever you can do. Just do something. It's very important. Also, I want to warn about antidepressant discontinuation syndrome. I am by no means advocating that you abruptly stop taking an SSRI or that you stop taking it all. You need to work in conjunction with your licensed healthcare provider, to manage your medications and make the decisions that are right for you. But I just want to point out, if you've been using an antidepressant for 6 weeks or more, and you just abruptly stop taking it, there is a 20% chance you'll experience this antidepressant discontinuation syndrome. Now, it's characterized typically by flu-like symptoms, insomnia, nausea, vertigo, potentially electric shock sensations, anxiety, agitation, and a bunch of other things. It varies from one person to another. The syndrome is usually mild, although on rare occasion, you actually may need to be hospitalized. Now, the symptoms typically persist for 1 to 2 weeks. However, the symptoms can usually be terminated just by restarting the antidepressant. Now, in order to avoid this discontinuation syndrome, like I said, if you abruptly stop, there's about a 1 in 5 chance you're going to have this discontinuation syndrome. To avoid it, you have to gradually decrease the dose over a 6 to 8 week period. And you need to work with your doctor on this, really. You need to be supervised. And then that will minimize the risk. Now, why am I talking about this? Like I said, I'm not advocating that you stop your antidepressant if you're taking one. I'm mentioning this because I'm realistic. Here's a survey that shows that nearly 1 in 3 people have at some time stopped taking a prescription medication without notifying their healthcare provider. And that's a dangerous thing. If you abruptly stop your SSRI and you have this discontinuation syndrome, and you go to the doctor because you're not sure what it is and they're not sure what it is, you could be diagnosed with something altogether different, given medications that you don't need, and end up in more trouble. So it's a big deal. You need to keep your doctor in the loop. You need to do things right. And that's all. I just want to say I have a book coming out soon. It's for people who have had an ablation for a cardiac arrhythmia, like SVT or atrial fibrillation or atrial flutter. So if you've had an ablation like that, or you know someone who has, and you or they want to minimize the risk of ever experiencing another arrhythmia again, I'm working on a book to help people do that. Right now, the tentative title for the book is After Ablation, but that may change. So if you or someone else you know may be interested, I recommend subscribing to the channel, and I'll make an announcement when the book is available. So that's it for today. Thank you for tuning in, and I'll see you next time.